as a neurology resident, I was really interested in the cause of cryptogenic stroke. Oftentimes when you're on the stroke service, the reason that patients have strokes is not found while they're in the hospital, and especially when patients are young and they have strokes, that can further complicate the diagnostic process.
In our article, we outline the different presentations of TTP, including cryptogenic stroke, as well as further management, including laboratory evaluation, imaging, and management of this condition.
My name is Emma Wetmore, and I'm a second-year neurology resident at the Mayo Clinic in Rochester.
And I'm Emma St. Martin. I'm a second-year hematology and medical oncology fellow here in Rochester.
And we're here to talk about a case report that was recently published in Mayo Clinic Proceedings called Arterial Thrombotic Event in TTP Predating the Development of Microangiopathic Hemolytic Anemia and Thrombocytopenia. Our report outlines the clinical progression of a male in his mid-30s who presented to the emergency room and was found to have a splenic infarction. At the time, laboratory analysis did not find any findings of anemia or thrombocytopenia, and he was discharged from the emergency room with the thought that this was caused by atrial fibrillation. Over the course of the next month, he did present to the emergency department for various symptoms, including chest pain that were mostly attributed to anxiety. And through those visits, CBCs were also repeated, and no findings of thrombocytopenia were found, except at his 6th emergency department visit 1 month later. 2 days after that visit, he came to the emergency department with focal neurologic findings and was found to have both a cerebral and renal infarction. At that time, laboratory analysis was repeated, and he was found to have a platelet count of 41, as well as an ADAM-TS13 level that was very low. At the time, he was diagnosed with TTP, and he was treated appropriately, and his platelet count recovered. So the purpose of publishing this study was to outline atypical presentations of TTP.
So TTP is a condition in which there is an autoantibody against the ADAM-TS13 enzyme. The ADAM-TS13 enzyme is normally responsible for cleaving von Willebrand factor. When they are not able to appropriately cleave von Willebrand factor, you have excessively large multimers in the circulation along the vessel endothelium, and those can bind and grab platelets, which then leads to excessive platelet aggregation and clumping and the formation of thrombi. When these platelet thrombi form, they can then shear red blood cells that are passing through the bloodstream, and this leads to the hemolytic component of the disease. So you get both a hemolytic anemia as well as thrombocytopenia that can lead to, paradoxically, excessive thrombotic events, including arterial and venous thrombi, as our patient had evidence of. TTP, although we say that it's a benign hematologic condition, it's not a blood cancer, it's not a malignancy, it's not actually a benign condition. As you can see, it has very significant clinical implications for our patients. They can have very severe clinical presentations like strokes and other infarcts in the body. And so I think sometimes we favor calling benign hematology classical hematology to get away from the idea that these benign conditions are not actually as benign as we are trying to initially say that they are. So it's a severe life-threatening illness. This is one of the indications to emergently hospitalize somebody, call in a hematologist, an on-call hematology fellow, and start emergent treatment. Typically, TTP, you start treatment up front with plasma exchange or PLEX to remove the circulating autoantibody against ADAM-TS13 from circulation, and you also start immunosuppressive agents, things like steroids or rituximab. This patient required lots of different treatments and many sessions of PLEX in order to have improvement in his treatment, which also added complexity to his case. Not only did he have a delay in diagnosis because of his atypical presentation, he required more than the typical patient in terms of treatment in order to stabilize his levels and get it to a safe point where he could safely leave the hospital.
In the case of this patient, he presented to the emergency department with a splenic infarction 1 month prior to his presentation with a cerebral and renal infarction. So this really interested me because the laboratory findings for diagnosing TTP were not shown until 1 month after his splenic infarction was found. And so I looked in the literature and found that there was actually a case series by Matthews which showed that cerebral infarctions have been proven to occur for up to years prior than the diagnosis of TTP was able to be made through laboratory analysis. Our case report is unique in that our patient had a splenic infarction 1 month prior to the laboratory findings being found. And to our knowledge, this is the first time that this has been recorded in the literature. So especially from a hematologic perspective as well as a neurologic perspective, this is very important to show that TTP can be the root cause of infarctions. They can occur anywhere in the body, and it's important to be kept in the differential diagnosis for patients who are presenting with cryptogenic stroke so that future strokes don't occur without that diagnosis being made.
So if you would like to learn more about cryptogenic stroke and the different presentations of TTP, as well as some of the management and further workup of these cases, please read our article at Mayo Clinic Proceedings.
Thank you.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com/Mayo Proceedings, or journal updates on Facebook, www.facebook.com/Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.